Started.
Hello, so welcome everyone. Today we are very happy to have Dr. Tom Abell to give the endocrine grand rounds. He'll be talking on gastroparesis syndromes and the role of diabetes. Dr. Abell is very well known in the field of gastroenterology and particularly in gastric motility. He has been kind of the guru of gastroparesis in the United States and across the world. He is professor of medicine and the Arthur Schoen Chair in Gastroenterology in the Division of Gastroenterology at University of Louisville. He has extensive experience in clinical care, clinical research, mentoring a large number of students, fellows, faculty over his distinguished career. He has had multiple NIH grants and also industry grants to study various aspects of gastric motility and related disorders, and has been a pioneer in developing measures to improve the lives of individuals with gastroparesis. He has over 150 publications, 700 abstracts and posters presented, and numerous fellows and students that he has mentored. So without much delay, I would welcome Dr. Abell to talk to us on gastroparesis syndromes.
Great, good. And you can all see the screen? You can.
Yeah. Mm-hmm.
Let me know if not. And since we have a nice size, not a huge size, so if there are questions as we go along, you can interrupt me, or there'll certainly be time for later on. I originally had a lot more slides, which I cut down. So, but let me know if you can't hear me, you can't understand me, you can't see the slides, whatever. So, pleasure to be here today. Here's my disclosures. Most of my funding's from GPCRC, some industry work. I worked for many years with Up-to-Date and things like that, which they pay me for. I would do it for free, but they pay. And we've got some intellectual property things from the University of Mississippi that relate to diabetes and obesity, but none of that is active. So today I'm going to talk about gastroparesis syndromes and the role of diabetes. Secondly, discuss the diagnosis of gastroparesis, and third, detail some therapies. It's such a big topic that I realized I at least could not talk about it in 45 minutes and cover everything. So I've sort of selected out some aspects that are related to technology, but since I am fascinated with technology, there's a one story, even though my dad's family is from Kentucky, my mom's family is from Tennessee, I grew up on the plains out in South Dakota and was born in a blizzard, actually. But there's an early picture of me out in the snow with my mother's lawnmower trying to turn it into a spaceship. I was about 2 years old. So it's been technology's been a fascination of mine. But let me start out with an actual patient, a 58-year-old woman with a history of gastroparesis syndromes, which I'll talk more about, had diabetes, nausea, vomiting, abdominal pain, which are the three cardinal symptoms. Self-referred, actually, for further evaluation. Had a borderline delayed emptying test, which I'll talk about, and with improvements in her diabetes from endocrinology, her vomiting was improved, but still, she had some symptoms, and abdominal pain and other symptoms persisted, and was referred actually by endocrinology, but she also found her way to us. So I'll talk about her as we go along. So my first theme is about technology in medicine, which, despite my beginnings sitting on a vacuum cleaner as a 3-year-old, I've been interested in technology, and it's certainly been intertwined with the destiny of medicine, allows for new discoveries, and then the new discoveries allow for new technology. And we now have a lot of devices and in GI motility, and of course in diabetes. And some of these are wearable, digestible, and with the advent of artificial intelligence, we may have better outcomes. Certainly the epidemiology, as we're all reminded every day, is for common disorders is important. But I want to talk about the technology and diagnosis and treatment of GI motility disorders, especially with diabetes today. So how common are these disorders? Well, the motility disorders in general are very common. The NIH PROMIS study, their patient-reported outcome, and I'm going to talk about some numbers and then talk about one diagnostic technology, the smart pill, and another therapeutic technology, temporary stimulation. The NIH PROMIS study done at UCLA, published 3 years ago, realized that since there were over 100 million ambulatory GI visits in a year, they surveyed over 70,000 people and found that over 60% had one GI symptom in the past week. And what are those? Well, reflux about 30%, abdominal pain 25%, bloating, diarrhea, constipation around 20%, nausea, vomiting, my particular interest about 10%, fecal incontinence 5%. And diabetic patients have many of these symptoms. In fact, all of our diabetic patients at one point or another have all of these symptoms. Over the last 50 years, I've certainly been impressed with technology. Back when I've done kind of sort of a joke among the fellows. I've done 2 of everything, 2 residencies, 2 internships, 2 fellowships. But when I did my first residency, I got interested in technology and diagnosis and therapies. So now, in terms of diabetic gastroparesis, I could spend 2 hours talking just about this article that Dr. Krishnaswamy and I wrote, published almost exactly 3 years ago in Diabetes Therapy. And we actually thought initially we would have trouble getting it published because it was so long. It's the longest article I've ever written. But the essence is, first we look at diabetic gastroparesis, gastropathy, as part of an autonomic neuropathy. And once obstruction is excluded, then one deals with things like nutrition, hydration, symptoms, glycemic control. The article mentioned the new technologies with sensors and pumps, which you're very familiar with. Mentioned medications, bioelectric therapies, which we'll discuss today, and surgery. And of course, early and optimal glycemic control is the best. Without spending a lot of time on that, which I would love to, I want to just talk a little bit about control, even though it's not the main focus of today's talk. But glucose sensors and insulin pumps have made a big difference. We now have also some new drugs. There's a ghrelin agonist that's promising. We have a number of dopamine blockers that are safe and in trials, 5-HT4 agonists, some of which are available. The NK1 drugs are useful for vomiting. And even some of the new calcium gene-related peptide drugs may be helpful for diabetes. What about our patient? Well, this patient had followed up with the primary care doctor from provider for many years, had a glucose sensing insulin pump, and had been seen by another motility referral center and found her way to us. And we went through a review of systems, and she'd had multiple tests and procedures, as many patients with diabetes have had. The average time for diagnosis for the people we see in our NIH consortium is 5 to 10 years. And many of these patients are very high utilizers of healthcare. Even in 1995 dollars, from one study we did, the high utilizers were using in those dollars $250,000 a year on average, roughly. And in the pre-COVID era, as you may be well aware, up to 50% of all hospital and ER visits were felt to be diabetic related, with the costs being in the billions. So let's go back to GI motility disorders in general and then try to apply them to diabetes. So we measure symptoms and patient measures by patient-reported outcomes. We look at anatomy, which I'll show. We look at organ physiology. We look at serum measures and nutrition and metabolism. And our diabetes consortium, the Gastroparesis CRC, which which I've been part of we're in year 15 now here. We did publish a nice study looking at, nice because it was done by others, but designed by others, but we carried it out through NIDDK, looking at insulin pumps with sensors, improving diabetic-related outcomes. But in terms of diabetes as kind of the classic disorder for gastropathy, there are many more similarities and differences in diabetic and non-diabetic patients. In fact, our non-diabetic patients also have disordered hormonal status. Insulin, amylin, glucagon, which understandably are abnormal in diabetes, are actually abnormal in non-diabetic gastroparesis as well. And that's work from here, NIH-funded work, just published this year. Now, this is a full-thickness biopsy, which is traditionally very hard to get. This was gotten at the time of a J-tube placement of a patient who didn't have diabetes, a lady from northwest Tennessee near my mother's hometown, who had failed everything, and we finally put a J-tube in. And this full-thickness biopsy, which I don't know that you can see my pointer or not, but there's a serosa at the bottom, mucosa at the top. There's the inner muscle layer, outer muscle layer, one circular and longitudinal outer muscle layer. The in between, that area that's blue, is where the myenteric plexus is, and actually that's not an artifact. That's actually the classic change of progressive systemic sclerosis or scleroderma in somebody that met zero criteria for scleroderma. So some of these people that we see in clinic, and this lady was obese and had no skin changes, and I mentioned no diagnosis for scleroderma, but she did have the autoantibody, and that's what was going on with her. So what about more modern? That was 20, 30 years ago. On the top here on the left, these are endoscopic biopsies of a normal control, looking at the neuronal mucosal density. And on the right is diabetic gastroparesis, gastropathy, and you see the loss of muscles. Down below are the inner muscle layers, looking at the Cajal cells, named after Ramon Cajal, Cajal, who first described these over 100 years ago, later won the Nobel Prize. But you can identify the Cajal cell bodies. You can also see mast cells. And in diabetic gastroparesis, classically, you lose those mast cells. Excuse me, you lose the Cajal cells, which I call the spark plugs. And why is that important? Well, here's circular muscle ICC bodies. On the y-axis, x-axis is gastroparesis, unexplained nausea, vomiting, and controls. Normally, you have 5 or 6 of those ICCs per high-powered field. Once you get nausea and vomiting, you have a decrease on to about 3 to 4 per high-powered field. But you may not have delayed emptying, and that's very important with diabetes, because many of our patients don't have delayed emptying. And once you get around 2 or less, you have gastroparesis. So you have normal on the right. The middle is you get sort of, it's a cardiac analogy, you get angina, and on the left you get an MI. But so many people are said, well, gee, your gastric emptying is normal, you can't have gastroparesis, but actually you can have significant damage. And this was big news when it was published. This was actually from 25 of my patients in Mississippi. So here's an old stomach of the picture of the stomach, proximal and distal stomach. But what's important about it is realize the stomach is actually many parts. It's a proximal sphincter that when it's abnormal, it results in reflux. It's a proximal stomach that relaxes to allow you to eat, a distal stomach that grinds up, and then a pylorus that may or may not relax. And all of those are very important in functioning. Also electrically, which I've worked on for 40 years, here's electrical control activity. And with a contraction, you see a rise in the plateau potential. Intracellularly, extracellularly, you see a change. And mucosally, and you see a change. And with manometry, you see a change. And the reason this is important is this is work that I did as a fellow at my 4 years as a research fellow at Mayo Clinic. This was a way of measuring low-resolution electrical activity, external or internal, or part of the stomach. But now we can measure all of this cutaneously with high-resolution sensitivity, and we're already actually doing that investigationally here in Louisville. So what techniques do we use? Well, we use gastroduodenal manometry that I spent 4 years learning, kind of a forgotten area, and it's very cumbersome and technically difficult to do. It takes hours. But back in 1963, the British Medical Journal had said maybe you could have a pressure-sensitive capsule that measures pressure, temperature, and glass on the left, middle, and right. And that would measure pressure, temperature, and pH. And you can indeed do that. Here's the smart pill, which we now use. And we do this routinely at Jewish, that it's swallowable, wearable. People wear an external receiver has 5 days of battery life. And then when it comes back, you can look at gastric emptying by pH. You can look at motility by the contractions, and you can look at temperature to see when it leaves the body. So basically, it's a very useful technology. And here's an example of using the temperature the pH in green, going from out of the stomach into the rising pH in small bowel. And here's a normal gastric emptying in red. Here's delayed emptying in green, looking at pH, and in red in gastroparesis. So that's something we use a lot. You can also look at the actual pressure of small bowel and as it passes through it, and colon. And why is this important? Well, it allows us, for example, by smart pill to look at what's actually going on, and we'll see more about this patient in a minute. We also got interested in bioelectric therapies and the mechanism of action, but we used it in recent NIH work here as part of the Diabetes Complications Consortium. They award about 2 grants a year, and we got the 1 clinical grant a year in 2013-14 here to look at anatomy, autonomics, enteric, hormonal, and inflammatory, which would be another half hour for me just to tell you that study. But we were able to do that study here with both diabetic and non-diabetic patients. And in this patient, we referral center actually had ordered a smart pill because she was from out of town. And that showed borderline delayed gastric emptying, which we knew before, but very delayed small bowel transit and delayed colonic transit. And that probably would explain some of the persistent abdominal pain in this patient. The patient continued with a glucose insulin pump and had a trial of a GES device, which helped nausea, vomiting, and not pain, and it actually has a device as well. So the person has 2 devices. And is doing somewhat better, but we'll talk more about her later. So what about other technologies that we can use? Well, one thing we can do is, based on previous work, electrical recordings have evolved into neuromodulation, and we use bioelectric therapies, which can be implanted endoscopically and wirelessly. And the response to bioelectric therapies can reveal more about pathophysiology and GI motility disorders. So I can tell you a little bit about my first patient. When I went to left Rochester, Minnesota, and went to Memphis in the 1980s, I took over the running of the pancreas, the medical side of the pancreas transplant program, which I did for 12 years. So we saw end-stage diabetic patients, and we studied gastric emptyings on all those patients and autonomic function, and otherwise did the motility that we could do in the 1980s, and realized that not everybody that was symptomatic had bad motility, and not everybody that had bad motility was symptomatic. So there was a disconnection between those two. And I inherited a number of patients, one of whom was our very first patient with an electrical stimulator, who was actually the daughter of a malpractice attorney and the daughter of an anesthesiologist. And by the time I saw her, she'd been in the hospital for 2 years with a failed pancreas transplant. Intact renal transplant, was unfortunately drug dependent on narcotics inadvertently, and had not been out of the hospital for 2 years. So what we did was we put in a temporary device, and I'll talk to you more about that. And she was able to get out of the hospital and actually stayed alive until dying of renal failure several years later. But that was our very first patient in the world 30 years ago, 29 years ago, actually, this month. So what about bioelectric therapies? Well, there's a whole bunch of them. There's CNS ones for thalamic and transcranial. The thalamic one actually for Parkinson's won the Lasker Prize and may win the Nobel Prize. The vagal and auricular are used for vagal stimulators for epilepsy. Auricular stimulators are widely used for depression and migraine, and now are approved for abdominal pain in children and adolescents. Spinal cord stimulation for pain and for movement, and as you know, at Fraser they have one of the largest and longest experience in the world in spinal cord stimulation for movement and spinal cord injury. There's enteric, which I will talk about, low, medium, and high energy. There's sacral stimulation and tibial stimulation for pelvic floor disorders, which are also done widely here. In fact, so much so that we probably will be eligible as a center of excellence for the International Neurostem Society here in Louisville when the criteria get set up. And then there's electroacupuncture, which the anesthesiologists use a lot for chronic nausea vomiting and has acute and chronic effects. And all of these have some GI effects and more similarities of differences. In my Mondays, I spend as the associate editor for Neuromodulation, which is the main journal on this, and I'm the GI editor. So we've had actually a doubling in the last 5 years of number of manuscripts, and in the last year we've had a tripling of number of manuscripts. This area has just exploded. So here's something that we did on that patient with the diabetes. At the time, we were using fetal scalp electrodes from my former life as an OB doctor, and but this is put in endoscopically, and my colleague, Dr. Stocker, put these in with either screw or lay these clips, these electrodes in the stomach, and put them in with endoscopic clips. And what happens when you get that way? You're vomiting within 12 hours. You're vomiting. This is mean and median for 5 days from a large group of around 140 patients. Actually, the median goes to 0. So it's an incredibly strong antiemetic. And we use that as a way to select who's going to get a permanent device. And you probably see some of these patients. You see the ones that may not do well. But from our work here as part of the NIH Diabetes Control Complications Consortium, we show that these are antiemetic, it's antiarrhythmic, and there's electrical activity. It's a prokinetic, speeds up gastric emptying if delayed. It's anti-inflammatory, which I'm not going to show you slides today because it would take too much. It's autonomic, improves autonomic, particularly vagally. You can basically normalize the disordered glucagon, amylin, and insulin, and improves quality of life. That was all from that study. Then the other changes from other work, there's a central effect, there's a pancreatic effect. In fact, that's one of the strong things we found early on was people with chronic pancreatitis can improve their pancreatic function, probably by vagal mechanism. There's a small bowel effect. And that was from a study we did here with bad diabetic enteropathy with chronic diarrhea, showing we could decrease that diarrhea with stimulating the small bowel. You can improve ICCs. You can. There's a colonic effect. You can improve nutrition. There's an improvement in survival, including in diabetic and non-diabetics. There are metabolic effects in terms of hemoglobin, hemoglobin A1C. Decrease medications, decrease hospitalizations by about half your first year, and cost reductions, all of which we published earlier this year. So there's a lot of changes, but what do you see electrically? Well, here's somebody that had electrical activity at the time of, in this case, it was her, the she as a patient, and did not have diabetes, but have this low amplitude kind of rapid electrical activity, and then needed a battery change, because we use kind of medium and high energies, need a battery change almost 2 years later. And what you see is this much more normal, much higher amplitude, normal frequency, normal amplitude. So basically, you're so-called gastroverting the stomach with this electrical. What about evidence-based medicine? I would love to have had you talk about our NIH work with a glucose sensing device, but basically we have at least one open label article showing that. And for the stimulation devices that we've had, a higher bar. And since there were hundreds of articles, we needed to look at just those that were meta-analysis, control guidances, and control studies. So basically, there are 5 meta-analyses and guidances and 8 control studies. And I won't go through all of them, but they include NICE from the United Kingdom, from New Zealand. These 3 are from the U.S. And most of these were positive meta-analysis with neuromodulation. And then there's 8 publications, randomized control trial. I think the first author on 3 of those, but senior author on 3 more. So most of those are from our group. But the nice thing is that the French group, Dr. Ducoutey, did a large study in France looking in diabetics and non-diabetics, delayed or non-delayed emptying, with over 200 patients. That was funded by the French government. It cost basically 100 million euros to do. It took 10 years to do, but basically vomiting is significantly reduced in a double-blind randomized crossover study with adequate sample size. So I don't think there's going to be much question that it's a helpful therapy. This is our own work with double-blind randomized study. Here's on, and then off, and off, and then on. But what we didn't anticipate is that when you turn the device on and then turn it off again, you don't go to baseline. And so this group did not separate very well because these people that had the device on never actually went back to normal. So once you get stimulated for even 3 days, the body doesn't forget that. What about futures? Well, as you may or may not aware, there's a thing called SPARC, Stimulating Peripheral Activity to Relieve Conditions. That's NIH institute-wide, and going on for about 5 years. Will go on for another at least 5 years. And that's looking at new technologies, including anything, including stimulation for pain, things for the pancreas, artificial pancreas. There are a whole bunch of things that are part of this, but it's fascinating. It's been started out with basic science, and now getting into more the everyday activities. We've been using a new technology for high-resolution mapping electrically, which I think will be in the clinics at some point. We use a number of things off-label. I used to say my whole life is off-label, but that's because things take a long time to get applied. We use it in pediatrics as well. The pyloric therapies are very important, and I wish I had more time to tell you, but a certain number of people get fibrosis of the pylorus, and it doesn't distend. And so we have a thing called FLIP, F-L-I-P, functional luminal impedance planometry, that is done at UofL Hospital. And it can measure not only your esophagus, but your pylorus. And if your pylorus is abnormal, then we inject it with Botox. And if you respond to that, then we recommend pyloric therapies, which can be done endoscopically as well as surgically. So you may see people that have had pyloric therapies, they've had bioelectric therapies, they may not be on medications, many of which are hard or investigational, because the only drug we have, Reglan, right now is not approved for more than 6 weeks. Registries are important, and centers of excellence, which I think UofL is going to qualify as an INS center of excellence. So what about gastroparesis syndromes, and what about going back to diabetes? Well, from our NIH complications grant, we concluded that there are a number of initiating factors: immune, infection, genetic, environmental, resulting in systemic inflammation, thus associated with autonomic dysfunction, enteric anatomy, electrophysiologic, and hormonal imbalances. And I think the people that you tend to see in clinic, but certainly in the hospital, oftentimes are have all of these. And I'd like to, I'll close the last 15 minutes or so with some new ideas that pretty much Gundam and I are working on, and that may be the next level. So here's from our NIH work. You've got these autonomic disorders. Again, half our people with gastroparesis have migraine. A lot of them have interstitial cystitis. They have anorexia, dyspepsia, disordered emptying. They may have autoimmune inflammation, neuropathies. They may be hypercoagulable. They may have abdominal pain. They may have pepsia. May actually have rapid emptying. About half of ours are delayed and half of them are normal or non-delayed, and a certain number of those are rapid, so much so that we've liked the term diabetic gastropathy better, although it's not really caught on. Then there's the mast cells, the Cajal cells, nausea, vomiting, bloating, distension. And we think that stimulation, caloric therapies have the potential to improve all these. What I could have done, and should have been good, I guess, to have another slide, is improving glucose metabolism can probably improve all these as well, not only because people get nauseated when their glucose is elevated, but also because of the neuropathy, and I'll talk more about that in a minute. So what about our follow-up? The patient, again, has a diabetic enteropathy disorder, because it's not just the stomach, it's stomach and it's small bowel and colon. The glucose sensor-driven pump has helped. Smart pill helped with the diagnosis of the enteropathy. Bioelectric therapy helps with some symptoms, and we're now awaiting new approaches. For example, a number of options for the future, maybe new drugs. We have, if you have anybody with gastroparesis that's not doing well, we usually have about 3 trials at any one time. We have basically dopamine agonists. We usually have 5-HT4 drugs and neurokinin drugs. And until just a couple weeks ago, we had ghrelin agonists. We have continued development of devices. We have disruption in the sphincters. The trial's underway for that. We're about to study with the NIH on normalzyme controls, looking at flip studies. And I'd like to close in a minute after some conclusions about physiologic insulin resynchronization, which most of you know more than I do about. But so let me switch to that. There's diabetic gastroparesis, delayed emptying. There's diabetic gastropathy, where they have the symptoms and may not be delayed or may be rapid. And some of this may relate to their autonomic function as well. We just published a couple of weeks ago an article showing that you can predict whether it's delayed, very delayed, normal, rapid, or very rapid by the combination of electrical and autonomic measurements. It's likely related to insulin signaling, insulin resistance and sensitivity, maybe a role in hyperinsulinemia. This PIR, which I mentioned a minute ago, physiologic insulin resynchronization, may help. And there are some studies in the way that have been working with a proposed study that I'll talk about in a minute. But the idea is that since the loss of pulsatile insulin secretion goes away with insulin therapy, you may have that as part of the role of complications. There's a number of previous studies. There's a company called Diabetes Relief that's working with some high-risk groups, like people that have risk of losing limbs, and populations like Native American populations that have high incidence of diabetes and complications. We have about 1,000 patients here with diabetic gastroparesis or gastropathies that we call diabetic syndromes. Many have medications, many have bioelectric therapies. Some with surgical therapies, varying degrees of success. And we've hypothesized that this PIR therapy may result in improvements from baseline and in comparison with a non-PIR group of similar patients after 24 weeks. The idea is that they would come in for the first, for example, 12 weeks and get an infusion, basically with an artificial intelligence-like device of insulin episodically in a center like the Clinical Research Center, the Clinical Trials Unit, twice a week for 12 weeks and then once a week for 12 weeks. And then the other group of patients would not get that. It's standard of care. And we aim to see that the stable patients have been well characterized anatomically, physiologically, neurologically, and symptoms respond to the PIR better and the non-PIR treated patients. And we're now in the process of, I guess in Hollywood they would say we're pitching this protocol, and Dr. Marsh are going to help me put this together in terms of metabolic assessments that we have proposed, glycemia, A1Cs, and then measures of postprandial glucose and continuous glucose monitoring, and then insulin secretion with index and meal tolerance test derived indices. Also in other measurements of insulin resistance is noted here. We have insulin-glucose relationship during pulse therapy and lipid profiling, glucose, GLP-1, glucagon, GLP-1, and other measures. We would look at microalbuminuria, we would look at retinopathy assessments, screening instruments, and severity indices. So these people will be really well studied, and in as much detail GI-wise as endocrine-wise. We would have inflammatory markers, usually done through the lab at 5th floor and at UofL, GI and Hepatology and Nutrition, and then we look at CRPs, high sensitivity CRPs, and cytokine panels, as well as the gut microbiome, which includes not only the gut microbiome in terms of stool, but also the gut microbiome interface, which we could do endoscopically by doing those mucosal biopsies in the microbiome. So Sri gave me this really nice setup that he did, but here's hyperglycemia, in this case type 2 diabetes in the middle, there's gastropathy, on the left microvascular, macrovascular complications. We have an insulin secretory defect, insulin resistance, inflammation, microbial dysbiosis. And the evidence of this, as you may be aware even more than I am, is extremely strong now. So to be able to do this in a controlled trial is obviously very attractive, and we're hopeful. We also, as you know, there's a long history of insulin metabolism here. One of the world centers, and there's expertise in mathematics department here about metabolism of insulin. So we think it would be great, and there is interest in funding a study in Louisville. I didn't talk about the fact, but I should have probably, that patients with diabetes there are more that are disadvantaged patients, both economically, minorities, and culturally, that have these complications than non-complications. So, for example, African Americans have about 3 times the incidence of diabetic gastroparesis, and Hispanics also have a higher incidence. So we're hopeful that we could not only do this study, but also enroll some of those patients that have those complications. So what I've done today, I know I've maybe a little ahead of time, which is hopefully good. Time for questions. I reviewed some themes of technology and medicine for greater good. Looked at new technologies for use in GI motility, especially with diabetic gastropathies, which is the term I like. Reviewed the importance of timing for introduction of new technologies, and I think we're at the cusp of a great time. As I've learned about some of the newer glucose sensing technologies that other patients can get, and the fact they become more affordable. I have more and more people that I know are using them. I've described one new technique for diagnosis of GI motility disorders, the smart pill, but there's a whole group of others, and one new technique for therapy, temporal stimulator. But again, we hope there's going to be a lot more interventions. So again, gastroparesis symptoms are common, diabetes is common, both frequently seen together. I think the pathophysiologies are better understood, much better than they were 5 years ago, and compared to 25 years ago, there's no comparison. I think technology can help with diagnosis and treatment. New drugs are coming, new devices are being developed, and I hope you'll all wish us well in trying to get this study approved. If you have questions in my virtual world, I used to have an office, now I have a cell phone. You call me, text me, email me. If there are any of these patients, we have our clinic has moved to a new location in the Jewish complex. We're over in the outpatient care center on the 5th floor. And our old area, which was on the 3rd floor, still where our research area is, going to be spinal cord area. So we're going to be able to work along with spinal cord research there. But we review, we try and have a referral stay longer than 72 hours without getting assigned to somebody. And we have a new we have three GI docs now, and two nurse practitioner and a PA, and several surgeons that help us. So we have a lot of folks who will try to see people quickly. I'd like to thank my colleagues, collaborators, staff, funding agencies, the chance to speak, and especially the patients. And most importantly, today's event code is noted right here. So let me stop there and stop sharing, and hopefully, as I click to exit, if I understand, the chat will appear. So I hope that was not too much too fast, but it's kind of what I thought might be interesting today.
Thank you, Dr. Abell. That was great review. I had a question related to, since we have fellows on the call, I see Dr. Winters also, and he helped me edit the 50-page monograph that we wrote. So the question is, I noticed the smart pill that you were talking about the diagnosis. So is the standard of gastroparesis diagnosis going to be the smart pill versus the usual gastric emptying study that we now ordered through nuclear medicine?
Well, the gold standard is still gastric emptying, look at emptying, but from the new guidelines, which I'm one of the two senior authors of the new guidelines that will be out sometime, from College of Gastroenterology, we're going to talk about a number of ways. Gastric emptying is one way, smart pill is another way. There's not 100% concordance, but the advantage of the smart pill is you look at small bowel and colonic transit. So when people like the case that I mentioned, who was having improvement in nausea, vomiting, improvement in glucose, but still had pain, it was quite helpful to see that in her case, her colonic transit was delayed and her small bowel transit was very delayed. So I think in the future, you can do gastric emptying. You can also do breath testing, which is available now, which we use a lot in our trials. In the future, probably going to be able to use high sensitivity, high resolution electrogastrography, which can be helpful, and smart pill. I think any of those would be helpful.
Yes. So I was going to go ahead read out a question from the chat box to you. It's
Sure.
from the VA. I don't know if you can see it or I can read it to you. It's from the VA, from our nurse practitioner, Marian DeMiro. She asks, do you see gastroparesis resulting from high-dose cisplatin and also patients who have a indwelling feeding tube, a PEG?
Thanks for the question. Let me separate those two. My interest in nausea vomiting is so much so that I've worked with MD Anderson for 15 years. I actually spoken there about chemotherapy-related nausea vomiting, and one of our things that we're particularly interested in is for people that have chemotherapy-related nausea vomiting that haven't responded, trying to use temporary stimulation for them. In some cases, permanent stimulation. So, yeah, we do, and if there's a patient like that, we expedite them to try to get them seen like the next week or so. That's a long-term interest of mine, but we've actually published this, our data on this, and there is a cancer-related gastroparesis is up to date, has its own section, so it's very common. The other part of the question on PEG tubes, I wasn't sure. Again, the nice thing about if somebody has a PEG tube is we can put in a temporary lead and see if they're going to respond and leave it in for a while. So if you have anybody like that, we'd be more than happy to study. And if you're interested in the articles, just email me or text me, and I'll send you the articles that we published on. It's called Malignancy Associated Gastroparesis, or MAG, and it's been a long-term interest of ours. Oh, great.
Dr.
Great
Abell, what is the role of gastrointestinal hormones in GI motility disorders?
Well, I'm really glad you mentioned that, because when I was a fellow in the 80s, they were just sort of being discovered. One of my mentors was Bill Gull, who I think is now retired from UCLA, but he did a lot of the original work on hormonal activity in the gut. People have known that there are abnormalities with gastroparesis. What was surprising to us with our gastroparesis consortium work and our complications trial was that we knew that insulin would be disordered, and we figured amylin would be disordered since it's co-secreted with insulin, but we were not totally shocked that glucagon was abnormal. Was abnormal because abnormal glucagon can cause nausea, vomiting by itself. But we were really surprised that our non-diabetics also had those abnormalities, which is at this point I think totally unexplored. Other aspects like ghrelin, the ghrelin agonists are very useful for diabetic gastroparesis. The drug has been in phase 3 trials, but I don't know if it's going to continue, since AbbVie bought the company. AbbVie bought Allergan, so I'm not sure the drug is going to continue on to approval. But I think it's an area that really needs a lot of work, and I've advocated for any study we do, like if we're able to do this PIR study, that we try to look at hormonal gut hormones as well.
So Tom, so many of the Go ahead.
Go ahead, Dr. Winters. Mm-hmm.
Oh, so I was going to say, when we examine the patients, many of them have peripheral neuropathy or evidence for autonomic neuropathy. So how much is a neuropathy a proximal event in all of the motility issues that you've showed us?
Good question. We don't have the answer yet, but we're in the middle of a 5-year NIH study with our consortium looking at detailed neuropathic evaluation. Our core center there is Mass General. So we're doing these detailed neurologic testing on people and trying to determine the role of the neuropathy versus the gut. We did in our previous 5 years, we've already published this, the role of autonomic neuropathy, and about 80% of our patients have autonomic neuropathy, gastroparesis, which is what the Italians told us decades ago. But we just submitted an abstract on our findings with the detailed neurologic exams of people and with gastroparesis, both diabetic and non-diabetic.
How do you test for autonomic neuropathy of the celiac axis? I mean, how do you know you're not missing a large number of people when everyone doesn't have it?
Yeah, well, it's a good question. You don't know. Our surrogate that we've used for the NIH is heart rate variability, which works pretty well, but it's an indirect cardiac measure. My own work with the NIH and in Memphis was with direct measurements of traditional autonomic testing, vasocholinergic and sympathetic adrenergic testing, which is well established. But again, if you talk about the internal plexi, you don't have a way to tell those unless you can sample them directly.
That's what I thought. So when you do your gastric paresis studies, is it worthwhile to do nerve conduction studies of the celiac plexus? Is there anything to be learned?
Well, I'm sure you can. We've been mostly interested in people with pain and whether celiac blocks help. The data on that has been kind of mixed, whether celiac blocks help or not. But we try it a lot for intractable pain. I'm interested in whether some of these people would respond to the PAR approach to insulin resynchronization. That because we have just scores of patients, and I'm sure you've all seen them well, who just don't respond to anything. and they're miserable, and they don't hesitate to tell us that they're miserable, and then thus we become miserable. But it isn't about us; it's about them, and whether we can help them. I hope that answered your question.
Sure.
So there is a lot of day-to-day variation in these patients.
Yeah.
It's not like, there are periods when they are very sick and then they're perfectly fine for
Right.
months. So what explains that?
Good question. My own bias, because I've written about this and published on this, is that it's autonomically driven, because they're very similar. Some of the people have a cyclic pattern, almost like they have migraine and cyclic vomiting, which is one of my long-term interests. And there's a specific adrenergic defect you get with cyclic vomiting. It's part of migraine. And when you measure the diabetic patient with diabetes who have cyclic symptoms versus non-cyclic, many more of them have a sympathetic abnormality than not. So that's our hypothesis, because they become almost like migraine. And some of them can even tell you what day they're going to get sick. It's scary, And I remember a patient I had in Memphis who would always get a fever 2 days before, up to 102. He'd always get admitted, never septic. Then he would start vomiting. I'll never forget. And he would tell you what day it's going to occur. And it was like, oh, yeah, he was right. He was a security guard at one of our hospitals, and so we took care of him a lot. So I think it's autonomic mediated, and in that sense, circadian mediated.
Okay, any other questions? Okay, if not, thank you, Dr. Abell, for an excellent talk.
Appreciate it. It was helpful, and we appreciate all the patients you send. We're going to continue to do our best for everybody that you send.
Thank
Sure.
you, Dr. Abell. Wonderful.
Thank you.
Thank you. Okay, bye-bye.